away and moved the table out of the way and put a different lamp on there that wouldn't break when it fell over. And I came back, I did that, and I came back and it was all backward where she had it. So I said, dumb, use your knowledge. So I said, gee, Mom, what happened with the plan with the table? And she didn't say anything. She appreciated my help. She didn't want to offend me like our patients do not want to offend us by saying, no, I don't want to do that. And she didn't want to offend me. And my sister called me up and said, what is wrong with you? Leave our mother alone. Lamp was in her grandmother's house in that configuration with that rug in front of it when she was a girl. And she wants it like that. And I said, hey, you're right. You're right. I can't go into someone's house and say, with the best of intentions, okay, oh, I'm sorry, you need to do that, and this needs to go there, and we need to work together. So for me, it's a question of engagement, and are we working together? And we all learn hard lessons by doing things wrong, and things don't work out. So I was not being helpful by asking my own mother to do something that she couldn't do. Well, by moving some other things and making a little more space around that rickety table and the lamp, I don't know who's, great aunt whoozy what's it, and trying to prevent some falling that might happen from that, rather than saying, let's just get rid of this. So I think that some of these studies are showing us that an OT or an OT as a consultant can train people who are working in the community for what to look for, and to bring that knowledge back to the team. I've worked with children. I've worked many years with children with disabilities and their families, and certain, you can't just say, oh, they're in a walk-up apartment, we can't give them a wheelchair while they're waiting to get another apartment, an accessible apartment, which could take 5-10 years, because some people have a way to deal with that. So they have who stores the wheelchair on the first floor for them safely and helps them bring the child upstairs. And then they have a smaller little chair upstairs that will fit through the doors, and they don't have to haul the wheelchair up and down the stairs. Other people have a walk-up apartment and don't have that social support in their apartment, and we cannot give them, especially a heavy or a power wheelchair, because they can't leave it safely in the lobby, and they can't get it upstairs. So there are degrees of engagement that we need to develop, and we'll make mistakes and we get better at it. So let me ask you, let's say that somebody is going home and oh, they're not safe. What kind of things in the house might make it not safe other than rickety old table? Also not safe. Pets are wonderful. No, pets are wonderful for a lot of things, right? They're emotionally supportive there's lots of literature about the value of pets for people, helps with calming, things like that. But pets can be, people can have allergic reactions even if they didn't know they're not necessarily allergic, but they can start having, if they've got any tendency and respiratory problems, pets could worsen it, and the pets can trip people. Being well-meaning. Dogs especially are very well-meaning. You don't want them jumping on your 88-year-old grandmother. So pets, you got who would think? Ask about what pets you have and how active they are. Oh no. Anything else make it not safe? Stairs.
And again?
Rugs.
Rugs.
Right. Yeah. So you have the people who shuffle when you have Parkinson's, but and even with wall-to-wall carpeting, they get that carpeting so that it's shuffle on it hard, and the carpeting gets loose. So even when there's there's no loose edges or anything. Sometimes you have to think about it. The other thing, and I had conversations with other people I work with on teams about, is it better to have bare wood floors or linoleum or carpeting that you might trip on? Because if you fall, it's harder if you don't have the carpeting, but you might fall more easily if there's carpet. So there are some, they sound kind of maybe not as quite important as medication and surgery, but there are things that we need to know more about. To be safe, yes, you need. Okay, and what if nobody can be there all the time? Yeah, and can we think about using technology? What?
Life alert.
Yeah.
Well, let me just say, as the daughter of a mother who now has someone there, first you have to engage them. We weren't able to get someone in until stroke number 3. So, it's not always as easy as it seems.
Some things are easy and most things are not.
That's it.
But lighting, did somebody just say that?
Lighting.
You don't, most of you are not going to think about the lighting. It's okay, the light went out, you don't have great lighting at the top of the stairs. No big deal, it's okay. But people whose vision is a little less than it was, who don't see well when it's not so bright, are going to have some hard times with that. And there are these when you think about technology, well, what are we going to do? We have to get an electrician to put in another light. No, you can get these little stick-on things that you just touch and they light up. And so you can think about lots of things with lighting. But go back to technology. I think that, people talk a lot about telehealth, but there are lots of aspects to telehealth other than what we normally or typically talk about. Some of those things provide a check-in, a person who talks to you every day, even if they can't be there. A way for the person who's alone to be able to easily, push one button and connect with the person that they have designated, that they want to be able to call when they need to talk, not just medically, but when they need to talk. At night, as what happened with my mother, if they had a monitor in between the bedroom and the living room, they might have had a better opportunity of hearing that there was a problem and somebody waking up and doing something about it. So there are lots of forms of technology, and we need to help people to obtain them. A lot of them are not expensive. A lot of them are covered by Medicare and insurances. So I think somebody who knows those things can really be helpful on a primary care team and a discharge team, and any team that's looking to help people stay home and age in place safely. So physical barriers like stairs, rugs, things that are unsafe, even the little thing between the doorway, the little, what do they call it? Door sill. It sticks up. And you just think about your person who's not so steady on their feet. walking into the bathroom. You're going into the bathroom, you trip on that thing and you hit the tiles. No, you don't want that. So you need somebody to kind of look at all of those things. I have always worked with children, and I still do. And the stories I hear from parents of children with disabilities, and I often work with children who are on the spectrum, who require special education services, other kinds of services, OTPT, who have behaviors that are difficult to explain to people. Talk about needing a quarterback. These are people who job trying to do the best for their child or their children, and also often need to keep their job, because otherwise they don't have any health insurance and they're not saving towards retirement, and they need to keep their job. So what does the school say to them? I hear it all the time. People in the school say, oh, that parent doesn't care. They're never here in the school. They don't come to all the meetings. So they don't care. And what do you say? You hear someone say something like that, what do you say? I hear a student say that, I say, okay, stop right here. How do you know they don't care? What do they do that says they don't care? That's a judgment that you're making. Well, they don't come. Oh, well, what are some other reasons why they might not come? Oh, they might have to work during the day. When you ask, all the meetings are during the day. Oh, well, can't they take a day off and come to the OT session and the PT session and the speech therapy session? And yeah, sure, they can take a day off for all of you. And then they don't have any sick days for when their child is sick. So you reason out with people and you help them to understand other people. And what I do with parents is to say, you know, I bet you hear this, and I bet you hear that. And they say, I do, and it's killing me. On top of everything else I have to do, I have to listen to people's judgments about me. And I think that one of the barriers are those emotional barriers that keep a person, like a parent of a child with a disability, from going to a specialty appointment, because they don't want to hear again what the problem is. They don't want to hear it. They can't take it. I've got all these problems. I have all these services. I don't want to hear about that one. How important is it? So how do we get somebody who's totally overwhelmed like that to go to another appointment? What do we have to do? Other than calling, reminding them, which is extremely helpful. Extremely. What do they have to feel that would make them go to that appointment? That people care and that they're not going to be judged, but also that it's important. So when we tell somebody, okay, I want you to go to the audiologist, I need to follow that up with saying, if you go to the audiologist, you might be able, and we find out there's a hearing loss, you might be able to communicate with your child better. And other people have found that when the child can hear you better, they speak more frequently. And if their child's speaking is one of their major goals, and you tie that to the audiology appointment, they're much more likely to go to the audiology. I'm stating the obvious, but we sometimes forget that. We know it's important. We tell them it's important. They should go. Sometimes they don't. So research needs. We need to make sure we know what the big issues are for people that we're working with. Some of them are going to be community issues, definitely, and some are going to be just things that we get to know are things that happen commonly and we ask people about, right? Like the stairs. And we know in some areas people live in elevator buildings, but in other areas people live in walk-up buildings, et cetera. things like social support, what activities are available in the community. We want somebody to exercise. Some people have a gym in their building, but most of us don't. So how are they going to exercise? We have to go that next step with people and figure out how are they going to exercise. And I'm gonna make a case right here for, I know people talked previously about patient navigators. I don't use the word patient because most of the children I work with are not patients. They're just kids with ability, condition, but they're really not patients most of the time. But patient navigator, or what I prefer to think of as a community health worker. And community health workers, I think, we have a big research need to see how those community health workers and somebody like an OT can work with a team to keep people safe, living at home, active as possible, happy, as social as possible. We know how important that is for physical health, but to see whether we can improve adherence, et cetera, if we know more and we have somebody who can act as that community liaison to people who are at higher risk, who have multiple medical problems. And I could do my own little, it's not a advertisement. I don't need anything yet, but I just got a grant also, the same New York State Department of Health source my curriculum for community health work people, and to provide retraining and training for people in the community. And what these people will be are people who live in the community, people who understand their community. So I don't have to, if I don't live in the community, I have to go learn what's available. These are people who know what's available. They have to be people who have certain personality characteristics, non-judgmental, people who want to help other people, people who have had possibly their own illness experience, their own medical experience, their own disability experience, possibly, or with families, so they have some understanding. So these are people with personal characteristics that allow them to be helpful, and some training that we want to give in medical conditions and what to look for, red flags, et cetera. So very excited about that. And sorry I didn't have any PowerPoints, but you can just contact me and I'll remind you of anything you want to know.
Before you leave, are there questions? Comments?
On the last point where you were talking about with what you're getting ready to do, how would we, if you wanted to be involved in that, how would you go about it? You said just contact you, or?
I just got the grant. So yes, what I think what we will do, and we're looking for people who want to be trained as community health workers. We're gonna ask Dr. Straker. Yes, but we'll announce that through this network and other networks.
And the reason for this is that we're trying to make this an organized funnel. So we want to make sure we get all of the information, we're able to capture it, and that Dr. Kaplan then can get it in an organized way. So that would be the great way to do it. I want to thank Dr. Kaplan, and I want to ask her to just ease over to one of those chairs. I want to invite up Dr. Boujadier, Dr. Marilyn Fraser, Dr. Carla Booten Foster, Dr. Salifu. I'd like you all to take a chair. Goes as Dr. Marilyn Fraser. Okay. Dr. Salifu. Okay. All right. Please come up and sit on the stage. Our commissioner's leaving, so we say bye, Commissioner.
Thank you very much, Commissioner. We're really very pleased with your support.
Up on the- Yes. No. Dr. Foster's coming up too. We are combining two sessions, okay? Say again. And Dr. Gerard, please. Yes. Dr. Gerard? So we're combining a couple of sessions. My boss didn't know that. But since we are running late, we have convened the panel of those presenters who remain behind so that we can have some kind of discussion of where we go from here. And Dr. Boujadier, who is also a member of our executive committee, has kindly offered to help us with this, okay?
So I know it's getting late, and I know you're tired. So I promise you what Elizabeth Taylor promised her sixth husband, I'm not going to keep you for that long. First, I'd like you to join me, please, to congratulate the organizing committee and the Brooklyn Health Disparities Center really for this excellent and successful multidisciplinary initiative. So please, let's give them a round of applause. So throughout the day, several elegant and informative presentation about adherence or lack of it. I just want to remind everybody, some of you might not have been here the whole day, that there is a human cost to non-adherence, which is about 125,000 deaths per year, and a financial cost of about 100 billion per year. We've discussed the causes of non-adherence, and it seems that it's multifactorial, and the solutions are also complex and diverse. So what I'd like to do with the panelists is if we can focus or develop more on what I would call sustainable solutions, and how, I mean, what are the take-home messages to improve adherence? Again, as a reminder, I know we talked about the importance of education, communication, trust, culture, motivation, context, empowerment, peer support, community engagement, and policy changes. One thing that I noticed that was not really extensively covered today, and I'd like to start with that, which is the role of technologies in improving medication adherence. So if somebody would like to take that point and develop a little bit more of how we can use, like, for example, mobile technology in improving adherence, because nowadays I think, everybody has a smartphone, and even without smartphone, the old Nokia phone have text messaging where you can use it for, medication reminders or prescription refills, etc. So if somebody wants to volunteer and talk about that, maybe Dr. Sir.
So we're very fortunate to be in fact, I actually but I think it's important for us to develop reminders for patients of when to take their medications, to pick up their medications. Another thing that mobile technology is good for is for also having patients catalog what they're experiencing, because we tell patients to write down if you're having any signs or symptoms, and at the time they're experiencing something, they get a piece of paper that, that flutter went away, and I took it when I took this diabetes medication. What was my finger stick? So really maximizing, that can remind patients when to take their medication, to document any symptoms that they're having, and that way when they see the provider, they can have something that's documented that you can download. In terms of mobile technology, we're also not maximizing Facebook and to create social support. So
Social
part of
media.
adherence is also creating a social network, that it's okay to take medications, that we're there for you, we're supporting you. So really to maximize also social technology, especially when it comes to our younger generation taking medications to remove the stigma from a lot of medications, whether it's ART or medications for mental health, to really maximize social networks.
Anybody else wants to carry, especially, yes, please.
Can I just say that, oh, sorry.
No, go ahead, please.
There's a lot of technology that we're not using, not just us at Downstate, but people in the medical system in general, because we're not used to it, but a lot of it, of the remote monitoring at home, weighing, having a scale and there are patches they're developing for your skin to monitor your diabetes, blood sugar, that you don't have to finger stick, and it projects back to a medical center. And you get a call all of a sudden saying, you didn't step on the scale this morning. Oh, okay. There's a lot of that kind of remote monitoring that we could do more of.
I think that falls under the category of telemonitoring, and I'm glad you mentioned that. It was my next thing, but go ahead.
Thank you very much for staying this late, and I really appreciate all your efforts to come to this meeting. I think we all enjoyed it, and the whole idea is to create the conversation. There are so many checkpoints in everybody's life. The first checkpoint could be your home, the second could be your school, the next could be your nurse practitioner or doctor or community health worker. There are just so many checkpoints in the equation that leads to a healthy life. So what we are trying to do at BHDC is just to improve the conversation so that everybody is really aware that there is a problem. And if all these checkpoints, everybody is aware that there is a problem with adherence, and then these checkpoints, there's a mechanism to reinforce. So if I get to this checkpoint, it's reinforced to me that, oh, did you take your medicines? Do you know why you're taking your medicine? And at the next checkpoint, the same thing. And at the next checkpoint, the same thing, and so on and so forth. If everybody has knowledge and the awareness that we're trying to create, and everybody is playing their part at every single checkpoint in this conversation, I think we'll see a lot of positive change in the community. There will be a cultural change. It will be institutionalized. It will be in the community. And the community will also be empowered to empower themselves to do a lot of stuff. I think one of the conversations we had this morning was regarding the school system. I think the Deputy Board President, Diana Reyna, brought that point. We are so busy with sick people, but the healthy people actually are the ones that become sick later on. And they don't gain healthful behaviors before they become sick. So we're really missing a huge segment of the population who should have that information before they become sick. Because if it becomes part of your culture of doing something when you are in middle school or you are in high school or you go to college, then of course, doing that same thing when you become sick becomes much easier than when you become sick and you're trying to learn all over again. So I think part of the goal of the Health Disparities Center is really to create this awareness, create a conversation that is going on at all levels, so that hopefully in the future we'll have a cultural change in all these topics.
Another aspect that we touched on briefly, which is really impacting policies, and I know the Deputy Health Commissioner was here earlier. So within the framework of the Brooklyn Health Disparities Center, can anybody comment on, impacting policies, change, the policies that will fit within the, that will make, adherence and related thing easier?
Disparities Center, I think we have the unique opportunity, as I mentioned today, with being having a key partner that's a government entity. And I think that having the Office of the Brooklyn Borough President as our government entity gives us the opportunity to inform policy and inform policy with legislators as well. Things that we've done, and Dr. Salif, who just mentioned about the importance of engaging people earlier on in education and working with high school students, middle school students, and so forth. And a big part of our Disparities work in our community engagement core has been focused on summer internship programs for high school students. And these students go to community-based organizations. They learn about health disparities. So there's a didactic portion where they learn about health disparities and health initiatives, based organizations, and they conduct research projects. And research projects on various social determinants of health based on the organizations that they are participating with. And from that, we always ask them in their presentations, they have to present an oral presentation, they have to do poster presentations. And we ask them to think about the policy implications of all of their work. And at the end of it, they present those things at a closing ceremony where legislators come. So for instance, sometimes they've done work on cardiovascular disease and fitness and so forth, and talking to people about improving those things, but they may not be places where people can tap into to go and get fitness or get fit, and there may not be places within the communities where people can get access to food. So those are things that they bring to the forefront. They work with organizations to address those issues. So that's one of the ways in which we have engaged policy. Also thinking about increasing representation of people of color in the health professions, and the importance of having culturally competent, culturally congruent providers, and working with young people and starting out at a young age and making sure that they're culturally competent, and so that they'll be the better healthcare providers, and they'll improve on what some of the things and the mistakes that we have made along the way, and they'll be able to kind of remedy some of those things. So those are just some of the issues we have worked on around policy.
I think there are also other opportunities from existing policies. I think that looking at some of the statutory and regulatory changes that have taken place, particularly around the Affordable Care Act, how can we game it in a positive way to make it work for the health of the community? I think there are opportunities there. The other thing is to look at the whole structure of payment, and how can we, as we go about looking at how we deliver care, whether it's wellness or illness care, maximize what we do in order to achieve better outcomes within some of those existing value-based payment systems. I think there's opportunities there that we can.
So another point that was actually interesting was that adherence is not only medication. You have behavioral adherence, you have dietary adherence, and it always comes back, I think, to education. So can somebody comment on how you can incorporate the two, education and then the other non-medical adherences, within the Brooklyn Health Disparities Center?
I think we need to work with all of our providers as a multidisciplinary effort in a cohesive way to provide consistent education to our clients, that we have to work with the clients. They are our center for delivering that type of care and education to help them move towards improving patient adherence. And this is something we as providers and as community health workers must be able to do, must work together to do, and to increase that teamwork to help this particular client.
Any other comments related to education and improving adherence in general?
Right. My comment will be that all of you who have come to this symposium, you are now the ambassadors of this message, and that you'll be able to influence the next person, and the next person will influence the other person, and so on and so forth. But that's the real goal. The goal is to bring you here, have a discussion, and we hope that this discussion will actually explode from here into smaller discussions that will impact somebody's life. We would continue to have these kinds of engagements with the community and with our partners in these kinds of forums, the symposia. But the goal is really for you to take back the information and then impact those who are around you. But getting to that point, I think you cannot separate the adherence topic from the various small components. So what we're trying to do is whether you can adhere to something that is recommended to you. Is the ability to extend that conversation as Dr. Kaplan described. In other words, if you say somebody should go to do something, why don't you also listen to that person's side of the story and see whether the person can do it in the first place, or you can negotiate a better way to get the person to do it without having to, hurt the person in their schedule, in their work, in their environment, those kinds of things. So I think there's a lot to do in engaging people to make decisions. We're dictating. I think we have to get rid of the dictation. We have to really engage everybody in a way that enhances the way they are supposed to. I am a diabetic. I am the one who's supposed to get information. All right? I'm the one who's supposed to get better. But you have to understand my perspective before you tell me to exercise. Maybe I'm hurting my toes. Maybe the first thing I need is a neurologist, not exercise. So if you had listened to me, the first thing that you would have recommended probably would have been, I think the neurologist will fix your that is causing this sensitivity. Now you can stand, now you can exercise. So I think we have to get out of this business of dictating to people and then listening to them more and trying to understand their perspective and then influence the change from that perspective.
Well, one of the things I think sometimes we don't do as healthcare providers often enough is, instead of starting with this is what you should do to achieve these outcomes, is to say, what do you want? What do you want to achieve? Sometimes people say, I only want to live long enough to see my daughter have her baby, whatever. I want to be able to play tennis and run again. Okay, we can do that. But we don't start there. We start with what we know is going to help them the most with their health. And I think that cartoon was wonderful. What's the second best? Maybe I don't want the first best thing. It's too much of a sacrifice.
We should not be dictators. We should be engaging them.
As I promised of not keeping you for that long, so let's give a round of applause to our panelists. And thank you very much.
I don't know if this is still working, but I want to thank you so much. And if you can kind enough to fill out the evaluation form, the registration form, and we will see you again.
All right. Have a good day.